Record. Boom. All right, we're going. So welcome on Dr. Gabby Amor. Congratulations on the kind of the new title and stuff like that. So Gabby is a licensed physical therapist based out of kind of Tampa area now. Knew her from going through the master's program at UCF. And so she's here to talk all things ACL and kind of rehab, and hopefully educate me a little bit as we're going. So Gabby, welcome onto the podcast. Appreciate you coming.
Thank you for having me.
So Ben, got your degree in 2021. When did you graduate?
So got my undergrad from UCF as well in athletic training. So I've kind of been around the sports medicine world since 2010. 2014, because I graduated in 16.
Yeah.
So I've been around the sports medicine world there, and then worked for a few years with UCF Athletics, and then Orlando Sports Medicine, which is an outpatient sports ortho clinic in Orlando. And then from there went into PT school, and then graduated, 2021.
Beautiful. I'll be curious too, like how it's been blending, like having the athletic training background as well. I'm sure that's kind of helped out and been like an interesting kind of combination with physical therapy. So then all the physical therapy stuff these days is now like, hey, you have to get a doctorate, right? Or is that like most of them are now is kind of upgraded to a doctorate from, I guess it was just like a master's or undergrad before, is that right?
Yeah, so pretty much every program is now a doctorate level degree. And so it's a clinical doctorate. So you just get your 4 years of undergrad, make sure you're getting all the prereqs, and then you would apply for the 3-year doctorate degree. Some programs do like a flex program, which is you go visit a campus every few weekends and do your clinical portion or your hands-on portion, and then you have learning. So that's a really good option for people who, maybe are working full-time or don't have, like finances, stuff like that, and need to postpone it. And there's also expedited programs where they kind of cram everything in 2 years. But I think 2 years is a perfect time frame.
Yeah. So I didn't realize that because I knew you guys have like a clinical portion, like as well as the kind of academic stuff. I didn't realize that was still attached through the actual like doctoral program in the school. I thought it was like you had to graduate, get your degree, and then go do clinicals, and then like sit for like a licensing board. But that's all together within like the degree program.
Yeah. So the first year is strictly all didactic. So you're in the classroom 3 semesters, like every single semester, spring, summer, fall. And for the first year, you're diving into the books, learning everything you can learn, from examination of injuries to obviously anatomy, physiology. UCF has a great cadaver lab. So we were very blessed to be able to have hands-on experience with, slicing open our cadavers, looking at every single muscle, every nerve, all that stuff. But then after the first year, you have your first clinical, and then you go back to school, and then your end of your second year and then third year, it's pretty much all clinicals. You have some classes intertwined with different semesters, but second year and third year is majority clinical, and you have 4 total.
That's awesome. So when you come out, you're good to go. That's very cool. Because for some reason, I was thinking that was separate. Like back when I was going to be an engineer way back in the day, like you get your engineering degree and then you go and like intern or work for a place for a given amount of time. And then you sit for like a licensing like test, and then you become like an actual like quote unquote engineer. So I thought that was the same setup for you guys, but I like that much better that it's all kind of prepackaged, seems a little bit more organized.
Yeah, it's great too, because it kind of gives us exposure to different environments within physical therapy, because you've got obviously like what people usually think of is like, in your world, sports, orthopedics, stuff like that, injury prevention, injury rehabilitation. But then you've got this whole other side, which is, pediatrics, working with kids with neurological disorders. You've got in the hospital, taking care of acute patients. You've got in like retirement homes. So there's so many kind of displays of physical therapy in different environments. So you can kind of set out, if you want to try it out, you can try it out for 8 weeks, 12 weeks. And if you don't like it, going forward, like your next clinical can be something different.
That's cool. I didn't even think about it like that, the different like kind of niches or like applications almost that you could have, and that you guys get exposed to that. Because yeah, I imagine it's even like even if you're trying to set up a practice, like you kind of I would imagine would be at least geared towards one or more specific types. You might do a little bit of everything, but like it's going to be I would imagine it would be a little bit challenging to have like kind of seniors just trying to like kind of walk, retain a certain level of function right next to like a like Division I college at like just that environment, it'd be weird to be like a little kind of clashing. So that's kind of cool that you get that exposure and then can kind of find ones that you're most interested in.
Yeah, totally. And it's funny because a lot of my friends are like, oh yeah, ortho, bones, muscles, woohoo. And then we go through the program, they have clinicals and we have the different classes and they're like, oh man, like I want to work with strokes, spinal cord injuries, and like more of like neuro stuff. So yeah, it's definitely an interesting journey and you find yourself and your interests through it.
That is really cool. Yeah, I feel like most people, yeah, like, I mean, it's kind of the same thing in like the coaching, strength and conditioning world. Everyone's like, I want to be a college strength coach. I want to work with athletes. But the problem with our thing is you don't usually get exposed to it until you've graduated and gone and
Yeah.
interned or gotten the job. And you're like, yeah, maybe it's not for me. So it's cool that you guys get exposed to all of that from the get-go. Have you found one that you kind of tend to gravitate towards more than some of the others?
So when I was going through, I mean, just because of my background with athletic training, sports and ortho has always been kind of like my niche. But going through school, I was like, oh, maybe I like pediatrics. Like maybe I want to work with kids. But like I'm a very bubbly, energetic person, but I just don't know if I can keep that up at all times throughout the day.
Yeah.
But neuro, I mean, really like every realm of physical therapy I really enjoyed learning about and could see myself working in that environment. But I think my niche with ortho and sports is kind of holding through and through for now at least. So we'll see
Right
kind
now.
of.
No, that's awesome. Yeah, maybe you'll get your fill in a few years, but that's perfect because that leads us kind of right into where we're going today and where I'm kind of most interested in is talking about kind of rehab for athletes, particularly like that knee, that ACL. That's like I'll work with athletes coming off of a variety of things, largely soccer players, like hamstring, ankle, groin are kind of common ones, even kind of hip, lower back. But the one that I get people coming to like over and over again is that ACL tear. And that could maybe be a whole nother conversation of why we're seeing so many of those. Like maybe we'll get into those that a little bit later. But so I'll tend to do like I'm definitely not a physical therapist, rehab, anything like that, but I'll work with guys as they're getting into later stages of their rehab. They've either finished rehab and are trying to play, or they'll do my stuff kind of complementary to that. So kind of looking forward to picking your brains about all things kind of ACL, maybe starting with the surgery itself. So one of the things that I noticed when working with different guys is getting hands-on and things like that. Like I was very surprised in the beginning how many different scars I saw basically. Like everyone's looked very different. Some had the giant one down the knee, some had different spots. So as I was asking people different things, some had just tiny little dots almost. You could barely even tell there was anything there. It seemed like the big three, like surgeries, like I don't know, how did they get your ACL? Like what did they do for the surgery? And it was either the kind of hamstring, patellar tendon, or quad tendon. Those seem to be like kind of the big three. And it looks like the ones that you sent me, those were the big three as well. But I was kind of surprised, I guess, that there were so many different ones. Like I would have just thought like an ACL is an ACL. So I was just kind of curious, like why there are so many, like what would be the difference in like why a surgeon would opt for one versus the other? Is it just a comfort thing? Like, is there a reason, like depending on the injury, you know what I mean?
Yeah. So the quad tendon one isn't used as much as you would think. Usually it's the patellar tendon, hamstring, and then the allograft. So the allograft is like from a cadaver.
Okay.
So I had both ACLs reconstructed in my youth.
Oh, man, I did not know that. Right.
Yeah, I had my left and then my right done. I tore them on the same day exactly a year later. So the doctors kind of gave you an option. They were like, oh, well, for your age, for your like muscle strength, for what you plan on doing for your future, like athletics wise, here are three options. So with the allograft, they say sometimes, and I mean, I would have to look at research really to kind of get into the nitty gritty, but allograft is coming from a cadaver. So there is a chance that your body may reject the tissue. So I personally went with a graft that was my own tissue. And then patellar versus hamstring, my reasoning was that hamstring, because they take a sliver from your semimembranosus and your semitendinosus and gracilis. So gracilis is one of those medial groin muscles, and then semimembranosus and semitendinosus, they're those medial hamstring muscles. So there is a chance of weakness within the hamstring muscle if you do the hamstring graft. And with rehabilitation, from that standpoint, there's a longer period that you have to wait before you can activate the hamstring muscle. So I already have weak hamstrings as is, so I went with the patellar tendon graft. And I feel like this is one of the more commons, but this is the one where that incision is straight down the middle of the
large vertical one. Okay. Yeah.
Yeah. And the most difficult thing I think with the patellar tendon graft later on is a little bit more of that anterior knee pain.
And stuff like that.
Yeah, but I mean, like the stuff that you're doing with your athletes, the whole knee over toes, really stressing into eccentric loading is, I mean, it's made a difference for me in my own exercise and trying to rehabilitate my own knees, as well as some of my patients too, because I've been incorporating that more.
That's awesome. That's awesome. So that's interesting. Like it's still, I don't know, I guess seems like a little bit surprising to me that there's not like this is one's going to be more optimal than the other. I guess they both have pros, cons. Like maybe if you're looking at a basketball player with like a high, like lots of jumps and stuff like that versus like a sprinter, like you could maybe take
Exactly.
versus like just to try not to strain one that that they're going to use more.
Exactly.
But that's interesting. Like other than so you talked about with the hamstring being something that you're going to maybe delay loading a little bit longer, if that's one that it comes from. Is there other potential changes to the timeline or like the rehab structure, take one versus the other? Like the patella tendon, you said it's more of just like a risk down the road of potentially having a little bit of tendonitis and stuff like that. But does that change how you're going to do the rehab process in any way?
So patella tendon, they usually have a pretty like steady recovery. The only thing to consider, and every surgeon has a different protocol, so really taking note on that. But it depends too, because usually ACL injuries don't happen in isolation, right? There's usually like meniscus or an MCL or some other structure or tissue damage that you have to consider too. So like I have a patient now who is about 11 weeks post-op ACL, but he also had a medial meniscus repair. And medial meniscus has attachment to, or the hamstring has attachment to the medial meniscus. So if that's repaired and I'm tugging on the hamstring, sometimes we need to delay that hamstring activation too. So like kind of the coinciding factors from different tissue within the knee kind of depends your rehab process and how quickly you can move along with the patient.
That does make a lot of sense. And it does seem like too, there is sometimes it's just like a preference of like the surgeon, that they feel more comfortable with one like style of operation. They feel more that they're going to be more successful. That I didn't know with the hamstring one, the semitendinosus and membranosus, that they'll also take a little bit of that gracilis. Like why do they go up so high in there for that? Like I didn't know that they piece of that.
Well, think too of like the muscular insertion. So they, because they're taking the tendon, right? Like they're not taking full muscle belly.
Yeah.
Or they're taking like a little bit more of the thicker bandy part of it. And they kind of like twirl it up and knot it and make it a tight little ACL, right? So I just think the way that they kind of bunch together is the best way to make a tight, taut alternative for the ACL.
That's interesting.
But mind you, I'm not a pro at this.
Yeah, no worries, no worries. I know I'm gonna be asking you a lot of like very specific stuff that maybe out like about surgery and things like that.
No, it's okay. I mean, I definitely need to do more research on it because it's applicable. But just generally, like I went to a conference, a physical therapy conference a few weekends ago, and they were talking about like a new triad of injuries that can happen with a ACL injury. So they were talking about like bone damage, fracture, stuff like that, and that their rehab process delayed bending the knee past 9 or basically keeping it within 0 degrees to a 70-degree knee bend until like 6 weeks or so.
Oh,
Yeah, which is quite a bit because they kind of tell you like knee extension is number 1. And then number 2 is knee flexion. And you want to get up to like 120 degrees within 3 or 4 weeks. But they're having a delay with a different type of surgery if there's like a bone involvement or fracture to 90 degrees.
that's interesting. And with the knee extension too, like that tends to be something like I probably haven't focused on quite as much. Like I'm very good at, and we'll definitely get these guys getting into deep flexion early,
Yeah.
soonish, like where as soon as like they kind of can. And it does seem to be like that. The more we gain in flexion, the more we get an extension, without focusing on it quite as much. But there are definitely some guys, especially the ones that have waited a little bit longer after surgery to start the rehab process, that maybe have a little bit more trouble with that extension and with that lockout. Few different questions with all of that, because I do have some guys that have ACL and meniscus as well. Well, that tends to extend the kind of timeline of that return to sport, right? It also seems like I remember talking to some of the guys, like if it's just the ACL, you can get them moving again, at least starting to do like the rehab process pretty soon, pretty much immediately after surgery. But with the meniscus, they have to wait a certain amount of time because of the loading. Is that right?
So, like you mean for like weight bearing?
Yeah.
Yeah. So with meniscus, they tend to be a little bit more weight bearing, like a little bit longer weight bearing. But also too, like, I mean, you can start rehab immediately after surgery, right? Because the biggest thing post-op that needs to be addressed is quad activation. Because trauma, surgery, drills, hammers, nuts and bolts, like all it's basically like construction in your knee, right?
A lot. Yeah.
So, yeah, it's a lot. Like if you've ever watched a surgery, it's really interesting. But the quad goes through, a period of where it just doesn't want to activate, maybe from swelling, from trauma, whatever. So I actually did a study throughout my years in the program, and we haven't published it because they're still like continuing the study, but it's seeing if the quad setting exercise is reliable for patients within like 4 weeks 4 weeks post-op from ACL surgery. So we found that the quad setting exercise is good, and it basically increases or it decreases the time response for the muscle to contract.
Nice. You're talking about just like a classic wall hold?
So no, so like, here, I'll get on my yoga mat and show you. So if you were to put, like, so say they're still in a straight leg immobilizer, really acute post-op, you're gonna have, you can't even see my legs. There we go.
No, you're good. I got you. I'll describe it for people just listening.
You're gonna have their like relatively straight, right? So the quad setting exercise would be having like a little pillow or a towel or something under their knee, and literally just having them try to straighten their leg.
Got you.
And try to actively contract their quad.
That's awesome. Almost like a terminal knee extension, but like sitting down.
Exactly. It's pretty much terminal knee extension. Yeah.
Okay. That's great. That's great. Yeah. I've definitely noticed a couple of things. One, like you can definitely tell a difference on the guys that started their rehab process. Like you can tell who started the rehab process earlier and later, like even the ones that have waited just like 2 or 3 weeks, like there's a noticeable difference, particularly in stiffness or like range of motion. That's probably the biggest kind of change. It'll take them longer to start to work through some of this stuff, just because, like that immobilization, like without movement as soon as possible, will definitely kind of tend to tighten up right away. But also that quad activation is very interesting too. I feel like people don't realize that obviously the immobilization and stuff like that, that'll come from surgery, like you'll atrophy the muscle, but also that, I mean, just the wiring of the brain to the muscle, those neurological connections, like when we're having them do backwards walking or step ups or this type of stuff, where we're really trying to get into that kind of vastus medialis, that muscle will spend a lot of time really focusing on that. And they'll be doing the technique will be perfect. And like the good side will be lighten up. They'll really be on fire, but they literally just can't feel, like they feel the whole quad. They really can't get that activation of there. until they've done a certain number of repetitions, and maybe it's a week in or a couple days in, and all of a sudden it'll like finally come back and it'll switch on. They'll be like, oh, there it is. But it is interesting. Like they'll lose not just like the physical muscle mass, but the connection with the brain.
Yeah.
Firing piece. Like, yeah.
So we actually use like electrical stimulation. So if they're having like a really difficult time activating their muscle, we'll put, it's called Russian. The setting is called Russian, but basically it sends an electrical impulse to the muscle and basically has the muscle contract just from like the receptors, right? So then athlete is like, oh my God, my quad is contracting. And then we have them consciously contract too. So you're getting that unconscious stimuli from the electrical unit, and then you have them contract with it. So they're being like, okay, it's contracting, let me contract now and let me feel what this is like.
Yeah, it's a good idea. Like kind of preps them, primes them. Like,
yeah, exactly.
Can you do something as simple as like, see, I know they make a lot of those like E-stem devices more for like recovery and stuff like that. You see them in the CrossFit world a ton. Like, would even one of those devices work, or is it more of like you guys have like a kind of specific or medical grade one?
So those are kind of like for the superficial pain receptors. The setting isn't like, it goes based off of like amplitude and frequency and all that stuff. So I don't think those, I mean, some units might, some of those little take home units might, but the setting needs to be a little higher.
Got you. Deeper there. Okay, fantastic. So then looking into some of the kind of stages of progress and things like that. So what are some of, you sent me like an awesome list over here of like marks that you're looking for, 3 weeks, 6 weeks, 12 weeks, 20 weeks, and things like that, when you'll start to introduce different things. And one of the things that I probably don't have as much of in the work that I do is clear like markers or things like that I'm looking for, like a progress. It's more of we just kind of keep building back range of motion, keep getting strength. Like, okay, you can do it with body weight. Like we can continue making like steady progress, but we don't have as much of like, oh, you've done this, now you can do this, which is one thing that I think you guys have a lot more of in kind of the rehab process. So what are some of those big kind of landmarks that you guys are looking for, whether it's in terms of strength, in terms of loading, in terms of range of motion, like different things like that?
Yeah. So, I mean, right off the bat, like after they get out of their brace and crutches, we're looking for an even walking pattern where they're not compensating with their hip, with their toes. Sometimes like people will swing their leg around because they don't want to bend.
Yeah.
So really looking at gait patterns, when they're performing a squat, making sure that they're not shifted onto their uninvolved side. So again, that kind of weight shifting and loading response. Range of motion. So full range of motion for the knee is 0 degrees, completely straight to 135 degrees. So we're not technically looking for heel to butt, but we're looking for that full range of motion. Like I said, extension is the most important at first, and then get into flexion.
Real quick,
go ahead.
When you're talking about flexion, like where, just so I can visualize, because like obviously a lot of the stuff that my guys do is like we're really getting into that kind of knee over toe, full like kind of heel to butt, like either on a slant board or on a split squat. Like where would 135 degrees fall in relation to that?
So if this was their leg, this was their like foot, it would be around like here-ish, right? Okay. So not heel all the way to butt, but
below parallel. Like
this is 135.
Yeah, I just want to hit a little flex here.
I have nothing there.
That was perfect. Beaches that way.
Yeah.
All right, keep going. Thanks.
But yeah, so 135 is kind of what you're looking for. Obviously, soccer and like these different sports that have a little bit more dynamic range of motion, you're going to want to explore strength through those ranges. So it's not wrong to get them to complete like as far as they can go full flexion, because a lot of people have way more range than that. That's just the average kind of across the board, right?
Yeah.
But yeah, so once you kind of get to their mid or like post acute, kind of going in more of like 10 to 12 weeks, you can start doing plyometric stuff. So I delayed my kid a little bit because he was in his extension brace for a little longer and non weight bearing a little longer. But this is like, like little hopping, maybe some ickies on a ladder, doing like some ladder drills, just getting them to have single or double non-contact each leg. And again, that loading response. So making sure they can accept a load on a single leg.
Gotcha.
And then you kind of get them running, seeing what that feels like. Starting at a low cadence and then kind of working your way up. The cadence that the clinic I was at previously used was 175 for like runners.
When you say cadence, what do you mean? Like in terms of frequency of footsteps?
Yeah. So like often, exactly. Yeah. So we just set a metronome and then just let them coast. Maybe do intervals sometimes and just kind of get their tolerance for running up. So like 30 on, 30 off, see how they tolerate that 5 or 6 times and then continue going forward.
Yeah. Yeah. Very nice. And then some of the, like, as they're getting closer to actual return to sport, some of the kind of major tests that you guys use. I know you like the single leg hop test. I got a question on that because I'm not a huge fan of that one.
Yeah.
But some of the other ones that you guys are looking for and stuff like that. Like what are some of those?
Yeah. So single leg hop test is a staple. Like a triple jump. So it's like single, 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 double or single, single, double.
Yeah, land on 2. Okay. Yep.
Exactly. Yeah. Broad jump, just because I mean, a lot of this stuff is like, how well does your body react to the ground reaction, right? Yeah. How is your body able to stabilize your joints when you bounce off the ground? Another one that some people use if they have access to it, but it's a biodex, so it's an dynamometer. It measures like the torque of the quad and hamstring. They say 80% within 80% of the other leg. So you want to be like, if the other leg's 100, your involved has to be 80% of that.
Yeah. So with the single leg hop test in particular, I've always been like, I don't know, suspicious of that one because I feel like we're introducing the same mechanism of the ACL tear, which obviously we want to be able to tolerate, but I feel like the test itself, like the landing on one leg, like the way you have to shift to that side, like we're encouraging that ankle to collapse and that knee to kind of rotate in, which like obviously the same mechanism of like kind of most ACL tears.
Yeah.
So I tend to see like, unless it's at a very, very low amplitude, like almost every time you're going to see like that. And even in like people that are healthy, it's just like the way that the center of mass, like for you to get your center of mass over the foot, the hip has to kick out. So then like it's just the physics of it. It has to has to go to that inside, which I've always been a little like, I know, skeptical of, but I guess you guys are trying to do that intentionally just to see how they kind of handle the forces of that, or ideally would they be able to resist that and keep that more neutral to the outside? Like
exactly. So more of this dynamic like testing, like the single leg jump, like that stuff's pretty intense. So that's usually around 6 months and then a 12-month marker. So you're not like 6 months. Some people get return to play at 6 months, which I think is a little too crazy.
Yeah, I've definitely had a few guys that like, I just got cleared and like I know what they're doing with me. And I'm like, really? Like
yeah, I mean, I don't know. But so you just said it, biomechanically, we're trying to avoid that kind of valgus or inning of the knee and the pronation of the foot. But, it's tough, right? Like hopefully through, abduction strength of the hips, quad control to keep the knee stable, and really like response to the foot. I mean, we all know that foot control kind of comes from the hip too. So making sure that the athlete's prepared, because if they get exposure to that during a game, guess what's going to happen?
Yeah. Oh. But I always thought too, like with the comparison of that test, or even like just getting into regular training stuff, and they talk about like landing mechanics and stuff like that. Like it's very rare for like, so the single leg hop in particular, like if you're going to land on one foot, it's usually from the other foot, like more of a bound. And then obviously like you'll tend to see guys that will absorb or fall, like the same way you see these guys in the NBA, like landing from these massive dunks, like they're not sticking it, you'll absorb and stuff like that. So that was just, I always just have a hang up about that one in particular.
No, I get it. I mean, it's tough. And is it like a real predictor of what's going to happen game time? Like you sticking a landing on one leg? No, I'm like thinking of layups and stuff like that. I mean, that's
yeah. There's always like that continuation of motion in more of the sports stuff, like you land on the door, but like it carries through. And so yeah, like you're talking about, like the majority of what I focus on is just the increase of the load tolerance or the work capacity of all of the tissues through as great of a range of motion as we can. So like that vastus medialis, which we'll tend to see like will atrophy more than, like in particular, it tends to atrophy more than probably anywhere else. So we'll spend a lot of time focusing on kind of strength and hypertrophy of that, as well as obviously getting into some of these deeper ranges of motion, which we're going to get a little bit more love for the joint, for the tendons, and for the ligaments in there. And then I've been surprised at how much that hamstring will really they'll tend to lose, like weakness wise as well, whether or not they took the hamstring tendon or they took the patella tendon. Like putting these guys on a hamstring curl, like it's kind of shocking at how like, oh wow, I swear they'll progress faster in the Nordic than they will in like that hamstring curl in terms of weight, which obviously they just have different ranges of motion and stuff like that.
That Nordic.
Oh yeah, we love it, can't get enough of it.
Gosh.
So one of my questions too, or I guess like one of the main problems that I've kind of seen or always just had from a kind of whole like big picture perspective with like the rehab process in general is that you talk about like that 80% number a lot. Is that like the target of where you're like trying to get people to and stuff like that? And that it tends to be, so like your all's job will, to a certain extent, like you get them back to that 80%, and then like you'll still do continue stuff with them on like physical therapies. Now you're going to have like a strength and conditioning piece like attached to it and stuff like that. So you'll continue to kind of build from there. But that 80% number seems to be a big target that you guys hit. And then there's a lot of like kind of grayer, like the athlete's almost left to figure out the rest of it. So like
100%.
Yeah. And so like I find that as like a huge challenge for like me when I went through my injury in college, like breaking my ankle, coming back from surgery and stuff like that. And it's just like obviously you're 100% where you were at before you got injured at. So like my thought process, my goals, we always need to get you to 110, 120. Like you need to come back stronger than you were from that if we want to kind of reduce the chance of re-injury, because obviously the chances of re-injury, like the percentages on that are not great. And so it's a challenge because it's not necessarily like your guys' fault. Like you guys are doing your job to get them back to an 80%. It's just we don't seem to have a very structured place for them to go from, okay, you're done with it, like you're done with physical therapy, you're cleared, but you're not ready for full contact, like all that gray area of like return to sport. Like that is where I spend a lot of my time, but it's definitely, I don't know, it's a challenge. There's not a lot of that in like a kind of organized space for the entire country, the entire industry and stuff like that. It seems to be very pockets of it here and there. So I'm just like, I don't know, what is that? I'm sure it's a huge kind of frustration for you guys because you do all this work with them and you send them off and then they go and try and do something they're not ready for. And then all of that work kind of gets undone. So I'm just curious, like, what are your hopes for? What do you think is the best case scenario for athletes in that situation? Is it for PTs to start doing more and start branching out into more of the strength and conditioning space? Is it for more trainers to start to have like dip their toe into this return to sport protocols? Is it a mix of both? Like,
yeah, so I had a experience of this with going through my own injuries too. Like, okay, I went to PT for a little bit. First of all, insurance is a big thing, right?
Yeah.
So if you don't have good insurance that, copay is relatively affordable, like, because 2 to 3 times a week, I mean, for ACL, like we're trying to get you back, but when I went through, my insurance at the time only afforded me like a few months. And then, so I didn't get my full recovery. And
That's
then
a
going
whole
back
nother
to,
thing. I had guys that were like, I was doing physical therapy. Like, were you done? Nope, insurance stopped covering me. Like now I'm saying,
yeah, it's
oh
bad.
man,
It's bad.
yeah,
Luckily now, I think more PTs are doing this self-pay model.
yeah,
So we,
based. Like,
exactly.
I
So
know
you,
it limits you a lot, right? The insurance-based model too, like because you got everything you guys has to do has to be kind of cleared through insurance, right? So it can kind of
yeah,
limit what
exactly.
you do.
Yeah. So self-pay, it is very good. It gives people opportunity to come see a doctor, physical therapy without insurance if they don't have it, right? So in Florida, for physical therapists, we have direct access. So they don't even have to see a doctor before coming to us. They can come
All right.
straight to us. They don't need a script, and we'll see them for 30 days without a script from a physician. But other facilities do like cash based. You can get a program, like a membership sort of ordeal. And still the PT is going to work with you. But yeah, I mean, it's tough. I do, coming from the sportsy background, I do think it's so important for athletes to seek continued care that it's sports specific. So I love when high schools have strength coaching or like weightlifting or whatever, but some sort of sports specific programming that strengthens them throughout their off season, because it's huge. Like it makes such a difference. And I think a lot of PTs and strength conditioning coaches definitely, I mean, I know a ton who collaborate together, but I think, just having the knowledge of who's in your area that you can refer your athlete out to is really important too.
Yeah, 100%. I do think that the early integration of more of like the strength conditioning and stuff like that, especially as I mean, these days sports and stuff like that are so much more like the volume of it so much higher. It's year round and stuff like that, that it's something that to be that much more important. Like we know the research is there on the role of strength and conditioning and reduction of injuries and stuff like that, but I'd say it's even more important when you're playing the same sport year round. You're not getting either an off season, you're not getting exposed to different sports, so like that you can very much like the sports specificity is a thing that everybody wants and things like that in training, but can also be a bit of a double-edged sword because you'll build up very strong imbalances and all these different.
Yeah. Yeah. I mean, I think collaboration amongst everyone that your patient or athlete comes into contact to, like the athletic trainer, their physician, their strength and conditioning coach, their PT. I mean, it's a whole collaborative team, because truly, like if you're investing in this athlete to get them back to return to play and succeed, you should kind of be chatting with everyone,
Yeah.
kind of see how you're on the same page.
And so with that integration piece, like a lot of my athletes that are doing their rehab and stuff like that are working with me and they're working with a like a physical therapist at the same time. So like not in the same session, but like they'll come to me twice a week and they'll go do physical therapy once or twice a week or something like
Yeah.
that. In your world, like what is my job in your eyes if they're also doing physical therapy? Like, how would you like us to communicate? What are some things you would love me to be doing with them, staying away from them, things like that?
Yeah. I mean, I think it's great, because I even tell like my ACLs like, hey, or all my knees, like, hey, we're going to be focusing on this in therapy, but go ahead and hit legs or do some sort of strengthening. Yeah. 3 times outside here. So when they're coming in, we're working on things that are a little bit more provocative or a little bit more stress invoking to the area. That maybe we know they would have difficulty with, so we can try to modify any exercises. But like, say they just need to squat, or say they need to do like lunges, or like a little bit more dynamic movements. Sometimes we don't have a time for that. I mean, it's an hour time slot.
Yeah.
So I think once they get comfortable doing whatever within the PT clinic, I feel comfortable having my patient do that outside. Like I'm not going to restrict their exercise and strength improvement to just in the clinic, because I know that they're capable. I know that they're determined to return to play. The only thing, like communication between the strength conditioning coach and the physical therapist, would be any precautions. and overdoing it. Because I think overdoing it is a thing that with the athletic population and specifically,
Yeah, very prone to.
not really anybody else, but just the athlete.
Yeah.
Overdoing it. I mean, they want to get back ASAP, right? So making sure, because at the like 4 month mark, they're like, oh no, I'm ready to go. That's
Yeah.
usually the time frame that is not so hot. So kind of maintaining their focus and like, this is our goal. Don't go past the goal, like go right up to it. It's really important.
Yeah, 100%. And then especially that, because you guys will tend to see people like once or twice a week, so like that homework piece and stuff like that. I know like the athlete population, it's rarely an issue, or maybe less of an issue, but just the whole like kind of patient adherence and stuff like that to the stuff that they're supposed to do can be a challenge for you guys. So
Yeah.
I can imagine that having an actual pair of eyes or something like that to be there for, they're just going to get much more quality out of the stuff that you're trying to have them do. And all tend to, like you're saying, I'll let you guys do, if they're working with me and with physical therapists and stuff like that, I'll let you guys be the ones that start to introduce the kind of plyometrics and kind of cutting and moving and stuff like that. Cause like that's, I know you guys have much clearer delineations of, okay, we're going to do this at this stage, this at this stage. And I'm just going to continue to work on loading and range of motion, building up that kind of tissue quality, that tissue capacity, just to make all of that stuff a little bit easier. It's funny, a lot of my guys that either as they've finished physical therapy or are finishing physical therapy and stuff like that will start to get back into the field like on their own. And so it's great for me because I try and just, my real goal is to instill that kind of trust or confidence again, like in an injury. They all know that times where you've had an injury and you've come back and like physically you're 100%, but mentally you're still like you don't really trust it. For me, that's one of the biggest markers of like knowing that, okay, you're ready to go again, is when you go and knock a ball around one day, like, okay, yeah, I feel good. Next day you go and you do a little like rondo and you get moving, you come back and you feel good. And then as you start to ease back into it and you can trust yourself, for me, that's my biggest goal. It's the biggest thing I'm trying to give the athletes, is that trust, that confidence again, to be able to go and put their foot in the ground and go play. Like when you can come back and they're like, oh, I played an hour last night and I didn't even think about my knee, or I forgot about it. That's kind of the ultimate goal.
Yeah. Trust and confidence is huge when recovering from an injury. And like there's, so we have a class in PT school called pain neuroscience. So it's basically like teaching patients about pain and displaying your language in a way that doesn't make the person have like a heightened interpretation of their pain or whatever. So fear avoidance of an injury is a huge thing that we see, especially in the athletic population. Shoulders, elbows, knees, ankles, that they're scared to get back to it because one, they think they're going to re-injure, two, they're going to get hurt again, or they're just scared of getting hurt. So then their performance is not at a full 100% where muscles are active, everything's working intertwined. Then it's like a lower level, and then they're more prone to injury.
Yeah, I mean, everyone, like, I think any athlete can tell you, like, it's when you're playing scared or trying not to get hurt or trying to pull out of tackles or contact and stuff like that, that's when you're more likely to get hurt. It's when like that little bit of, like, it's like driving a race car, like hesitation can be as dangerous as like as speeding, as going too fast kind of thing. So that can be, that's 100%. A couple of more like kind of specific questions. So I have some guys that are, one in particular that has, he had several things done. It was ACL, meniscus, and I think he might have strained one of like the lateral ones. But the thing with him is he waited quite a long time. Like it might have been like 4 months after surgery before like kind of rehab started and stuff like that. So he's still got like, he's pretty, like we've been training for a while. He's pretty advanced. He's made a lot of progress, especially with flexion, but still lacks a little bit like that final bit of extension. Like he can get there, but it's a little bit of a challenge. What are some things?
Message with?
What's that? Yes, actually. Yeah. So what are some things that you might work with someone like that he's been around for a while, like he's got good loading and trust and confidence, but there's still some stiffness in there?
So joint mobilization is a big one. So There's one technique in particular that's pretty easy, but it's kind of like CPR on the knee. So you have their legs straight, you put one hand on the tibia, one hand on the femur, and you're kind of just like cupping the knee like this and kind of pushing down. That's a good one for like that terminal knee extension. Exercise wise, retro walking. So backwards resisted walking is great because like quads are active, whatever, but you do maintain a level of knee bend throughout the whole thing. So maybe just like a backward walking or retro walking on a treadmill to get them to like have that full terminal knee extension. Also like banded terminal knee extension.
Yeah.
So like sitting off the edge of a table or something and doing like a full knee extension with like light weights, get them comfortable with holding it and then moving up. So I'm doing it with my foot now, you can't see, but just like putting an ankle weight or something. I mean, this may seem kind of minuscule, but over time, going from here to here is a big deal.
Yeah,
right?
For sure. That distinction between the backwards sled and the backwards walking is very interesting. It makes a lot of sense how you say it, but I hadn't thought about it like you definitely do. The emphasis on the backwards sled is not quite that full lockout. It's a little bit short of that, like where the greatest load is. And yeah, you will tend to stay a little bit more squatted and stuff like that versus getting that last little bit. So that's actually very interesting. I like that.
Yeah, just like throw them on a treadmill, have them do some, like hold on to the sides, do some slow retro walks. Or if you have a tread that you can push yourself, I don't know what those are called.
Yeah,
but like where you don't turn it on, you just have them push.
Yeah.
That's great because it gives them a little bit of that resistance, but it's not quite like a pulse, like a reverse sled pull.
I've had a couple of guys as well with an almost like pinprick, like on the inside of the knee right here, like a little dot that will almost kind of poke out. And sometimes it's painful, sometimes it's not. It seems like the more that we've trained, the less painful that it's gotten. I haven't been entirely sure of like what it is. I've talked to we have another coach at the gym who's a former CFL, like played Canadian Football League, who had ACLs done long time ago. Like he's long since retired, and said he had that, and but that it's gone away. That it was more of like kind of cartilage or something that's come from the damage, like during the injury, like how some of that kind of stuff will squirt out and form, like can solidify a little bit or like kind of calcify. But I was just curious, like if you run into that, like what that is specifically.
Yeah.
It's really just like a little dot, like it looks almost like a pimple under the skin.
Yeah, so there's something called, so it's a tissue, it's called plica, and basically it's within the knee joint, there's like folds of tissue. So it's a membranous tissue, and there's usually like 4 in each knee. And what happens is sometimes like it can get caught up, and then it'll cause what it's called Plica Syndrome. So it's like irritation of that medial knee, some swelling, and if it, maybe some instability, because any sort of increased swelling can increase instability. So that's one option, that plica. And then there's also that medial, it's not like right at the kneecap, right? It's a little bit more in the joint space.
Yeah, exactly.
Okay. So that kind of sounds plica-ish. If it was like right on the kneecap, like I have a lot of patients who have like kneecap pain. So there's like fat pads there too that can get irritated.
Yeah, no, it's definitely more in that joint space in the side.
Yeah. So maybe plica, maybe do a little research there and see.
Yeah.
But that's not like a super common thing, but definitely can happen. Also too, like,
go ahead.
Sorry, like everything's connected through like the tissue and through all of the like fascia. So especially around the knee joint, and it's really cool to see like in the cadaver, but any sort of muscle tightness can cause some of that like myofascial disconnect, right? So
he's definitely couch stretch is a challenge.
Huh?
He said he's definitely tight. His couch stretch is something to see.
Yeah. So think of like anything that crosses the knee, gastroc, vastus medialis doesn't cross the knee, but anything like medial kind of towards that area, even soleus, just because how high up it goes. But Yeah, it's a little tough when these like weird things come up and you're like, oh, I don't know. I
Yeah,
don't
yeah, it was very specific. Yeah, and it's not like it's something that's really. It's more of like a nuisance than anything else, but it was just kind
Yeah.
of weird. He was
I
curious
always tell
about.
patients like if it doesn't cause you pain and discomfort, you're
Yeah,
fine.
you'll be okay. Walk it off. You'll be okay.
You're fine.
Speaking of, the last kind of area that I'm kind of want to touch on for this is as we're getting them back into movement, basically jogging, running, change of direction, and stuff like that. How much are you looking at paying attention to biomechanics and stuff like that? And what are you interested in? Because I tend to see a lot of these guys in particular, like after ACL, they tend to be quite externally rotated and flat footed. So like that foot will collapse pronate like quite a bit, which is then like you can kind of see where that, again, that mechanism, that ACL, kind of like what we talked about with the hop test and that sort of thing. Like it's the same, you can see how that could be reintroducing that same mechanism as they get back into stuff that's more high speed. So we'll do some work as they're progressing in terms of just strength and stuff like that, and they're getting back into moving. We'll get into some stuff biomechanic wise, working on the arches of the feet, working on a little bit smoother rotation through like the entire kind of hip. But I'm curious, like some of the things that you're looking for, if some of that stuff's a big red flag, or if it's, you guys don't worry about it too much.
No, it's definitely a red flag. So biomechanically, I mean, the biggest thing is the knee valgus, right? So the knee collapsing inward and foot pronation. So foot pronation leads to knee valgus. Hip weakness, specifically glute medius, is the one that's going to be responsible for that collapse, right? So even when you see people walk and they start waddling, like their hips are like womp womp. So that's glute medius weakness because it's unable to stabilize the hips with a single leg balance. So getting them back to just normal walking and stuff like that, balance is a huge component. So not only testing their balance, so you could do static balance, like sit there or stand there and hold it for 30 seconds, but I like to incorporate like ball throws or maybe like taking TheraBands and doing like some sort of stability exercise or doing like a Palloff press while they're doing single leg stability, something that will kind of challenge them to either control medial lateral stability or anterior posterior stability. Also like kill their glute med, like kill them in abduction. You know, like single leg stance with a band around their knees, just like doing abduction with the opposite leg. That's not only getting the leg that's moving, but the stance leg too. You know, like monster walks out the wazoo, side lying, leg raises into abduction, you know, like stuff that we normally don't think about, like donkey kicks, fire hydrants. Get their glutes strong as heck. I think that's the most important thing for that like medial lateral sort of collapse into that horizontal plane. Because we work a lot with sagittal stuff, like, yeah, get the quad strong, get the hamstring strong. But the thing that's going to help with that collapse is going to be the glute med.
I'm a big fan of the like long duration iso holds of like the single leg stand where you just stand on one leg and lift the other one. Because yeah, you'll get like the connection between the brain and foot because they're standing, or between the foot and the glute. But yeah, you can tell. I like it one because it's almost like a diagnostic as well as a training tool, because you'll see where guys start to fatigue and start to flare up a lot of times, especially with these guys. You'll see the arches of the feet or their calf or their Achilles, their ankle will be on fire, and it's like, well, that's telling us something. And then the ones that are a little bit more locked in will get that hip working a little bit. So that's interesting. I like that.
Yeah, definitely. I mean, feet are huge. Like I think a lot of people don't focus on them as much. And I think I've learned that throughout this past year is like tibia anterior, gastroc, soleus, they all play such a role in that foot stability because you have to keep those turned on constantly when you're walking. And two, on a single leg stability, like they're constantly going back and forth between concentric, eccentric control. So yeah, big.
100%. I love it. All right, this has been awesome. Last couple of questions that I'm going to ask you before you go, a little bit different, a little unrelated. But what is, a little bit getting into a little bit more stuff about you. What's a book that you've read in the last year or two that's been very impactful on you that you'd like to share?
I've got it down here. So, okay, it's very like standard, but like it's very like typical self-improvement book. But I finished this not too long ago. It took me a while. I started reading it throughout PT school, and then I stopped because I got distracted. And then I picked it up again, and I'm not a big reader.
What's it called?
You Are a Badass.
Okay.
How to Stop Doubting Your Greatness and Start Living an Awesome Life.
Beautiful. I love it.
So it's one of the best sellers. I feel like everyone's read this book, but I guess except for you.
Yeah, I've been slacking.
But it's, really just getting you to kind of incorporate different things into your daily routine, into your daily life, and your perception of the universe and how you play a role into it.
That's beautiful. I love that. And then the last thing, what's something that you kind of believe or know or understand or have learned that you wish more people learned or understood?
Self-awareness.
Let's go. Yeah, I mean, you can't go wrong with that.
So I think now more so than ever, just working with people in pain and the general population, that a lot of people don't understand their own selves. And I just got my certification in pelvic health too. And, I've been working with women who aren't really self-aware of their own organs. And, that pain is not a normal thing to have, like through sex and through like many, like leakage is not normal, these, even for men too, like there's just so many things. I'll ask a patient to identify a structure on their body and they're like, what are you talking about? Like, I didn't know. So one thing I hope for people is just to be a little bit more mindful about themselves. And if they're in pain, don't seek a medicine, like seek movement. And I think that's definitely something that could change the whole healthcare field. But
100%, I love that. That's the pain is there for a reason, like it's a signal and stuff like that. So just
exactly, it's not bad. It's just your body telling you, like, hey, we need to change some stuff.
Yeah, no, for more people to just be in touch with their body, with their mind, their thoughts, their emotions, everything that's going on. Like there's so many different directions that can go, so many different applications. But yeah, as a general rule, I definitely think that's something that we can all practice a little bit more. We can all use a couple minutes a day just to kind of meditate and sit and notice what's going on. I definitely think would do a lot of good for people as individuals and people as a whole.
Yep, definitely.
Beautiful. Thank you so much, Gabby. This has been awesome. I've learned a lot, which is definitely my goal. So appreciate your time and teaching us all some stuff about the ACL and return to sport. It's definitely something that's seems to be borderline epidemic these days. So definitely something use more knowledge about. So appreciate you.
Of course. Thank you so much for having me.
My pleasure. Thanks, Gabby.